Hello everyone and welcome. My name is Jen Nolan and I'm one of the Programs Managers at Arthritis Victoria. As I'm sure you're aware, Arthritis Victoria, incorporating Osteoporosis Victoria, is a not-for-profit community-based organisation which works to achieve the best possible musculoskeletal health and wellbeing for all Victorians. In the week leading up to World Osteoporosis Day on Saturday, the 20th of October, Arthritis Victoria and Osteoporosis Victoria is very pleased to present for you this webinar titled Osteoporosis, a better understanding of its causes, management and prevention. It is astounding to think that every 5 to 6 minutes someone is admitted to an Australian hospital with an osteoporotic fracture. This statistic is expected to rise to every 3 to 4 minutes in the year 2021 as the population ages and the number of osteoporotic fractures increase. I would like to warmly welcome and thank Professor Kim Bennell, who will be our presenter for today. Kim is Professor of Physiotherapy and an Australian Research Council Future Fellow in the Department of Physiotherapy at the University of Melbourne. Kim's research interests are in the conservative management of chronic musculoskeletal conditions, including osteoporosis and osteoarthritis. She is a chief investigator on an NHMRC program grant in this area. Before asking Kim to commence, I just have a couple of housekeeping issues to run through. First of all, if you have any technical difficulties during the webinar, please refer to the message box on your screen to the right. Also, can I remind you that whilst Kim will answer questions at the end of her presentation, you can actually type questions for her at any time. Can I suggest that you don't leave your questions to the last minute in case we run out of time, as we will aim to finish strictly at 1:30 p.m. Eastern Summer Time. Finally, I would be very grateful if all participants could take a moment at the end of the webinar to complete the exit survey, as this information will greatly assist us in evaluating this webinar and planning future activities. Without further ado, I'll hand proceedings over to Kim. Thanks, Kim.
Thanks, Genevieve, and welcome to everybody, and thank you for joining us today and giving up probably your lunchtime. And firstly, I'd just like to apologise for my pretty strong cold and cough. So if I go mute during the talk, it's because I put myself on mute as I have a bit of a coughing fit. So hopefully that won't be too frequent. But so we're going to get started. But as I said, I'm very pleased to be talking about osteoporosis today, particularly in light of World Osteoporosis Day coming up. So just in terms of what I'm going to talk about today, I'm going to give sort of 5 main areas. Firstly, just a bit of background about osteoporosis and diagnosis. Secondly, just some short information about the medical management, then about nutrition, exercise, and finishing off with falls prevention. And also refer you to the Osteoporosis Australia website, where they have a lot of really good information for health professionals, and their medical guide and medical fact sheets have all been recently updated August 2012. So they have a lot of great information, some of which I'll be showing during the talk. So firstly, just starting off with the background. Now, osteoporosis, as defined by the World Health Organization, is a disease that's characterised by deterioration at the microarchitectural level of the bone, together with low bone density. That means you have a very fragile skeleton, and hence it's much more likely to fracture when loads placed through it. So you can see there on the left a picture of a healthy bone. The trabeculae are really thick and strong. There's not a lot of holes in it, compared with the picture on the right, where the trabeculae are very thin. There's not a lot of them, there's a lot of holes. So if you loaded that bone on the right, you could see how it would be much more likely to fracture than the bone on the left. So with osteoporosis, the bone itself is normal in composition, so unlike diseases such as osteomalacia, there's just less of it. And the clinical consequences of osteoporosis, as mentioned obviously, is low bone density, but having low bone density itself is actually asymptomatic. So there's probably quite a number of you out there that if we actually measured your bone density, you may find that you have got osteoporosis. But it's the fractures that are the real clinical sequelae that we can see of having osteoporosis, and they're at those clinically relevant sites, the wrist, the hip, the ankle, the spine, the shoulder, and so forth. But it's also worth noting that a number of vertebral fractures themselves can be asymptomatic and may only be picked up because someone goes off and has an X-ray and they see these old fractures in the spine. And of the numerous osteoporotic fractures admitted to hospital, this is data from 2007-2008 in Australia, of the 52,000 osteoporotic fractures that were actually admitted to hospital, and you must remember that a large number of osteoporotic fractures aren't necessarily admitted to hospital. So this is of the ones that are admitted to hospital. You can see that the majority of them are found in the hip and the pelvis, particularly your proximal femur, and then at other sites, particularly the wrist as well. And other clinical consequences, apart from fractures, is there can be a loss of height over time. It can be a slow loss of height, or it can actually be acutely. If someone has a couple of wedge fractures acutely, they can lose height acutely. And losing over 4 centimetres over 10 years is actually a clinical marker of osteoporosis, and can explain why, for example, my grandmother used to be taller than me and then ended up shorter than me. Kyphosis is another consequence, again, because of those wedge vertebral fractures. Reduced exercise tolerance, disability, and also a lot of people have a lot of fear and anxiety. They've been diagnosed with osteoporosis or they've had a fracture and they get very fearful and anxious that they're going to have another one or that they're going to have a fracture, and that makes them less likely to become active, and it's a bit of a downhill spiral. They do less activity, they become more functionally disabled, and so forth. So the determinants of osteoporotic fracture, we've already mentioned, obviously low bone density is one of the determinants of fracture. So a number of other things that can influence the strength of the bone can influence their risk of fracture. So not just the bone mineral density, but also the geometry of the bone. So bigger bones are going to be stronger bones, and so people with smaller bones are more likely to fracture. And also the structure of the bone, that microarterial architecture can influence whether or not one fractures, and they're more difficult to measure clinically, but still can play a role in influencing whether or not one suffers a fracture. And then, on the other hand, falls, and certainly falls is a risk factor for osteoporotic fracture, and most of your hip fractures, for example, occur because someone falls. So if we can prevent falls, we should be also able to help prevent a large majority of the fractures. And over our lifetime, our bone mass does change with age. So males have higher bone mass than females, and that's why they're less likely to suffer fractures. It's 1 in 3 men over the age of 65 will suffer a fracture, and 1 in 2 women over the age of 65. So even though it's more common in women, we also must remember that it's not just confined to women, that men also are at high risk of suffering an osteoporotic fracture. So what happens with our bone mass is that we reach our peak around about the 20s, and then there's a slow loss with age because our bone turnover, we lose a slight amount of bone each time our bone is turning over. And then in females, there's a more rapid loss of bone around the menopause when estrogen levels drop. And so it's thought that there are probably 2 main times where we can really try and improve our bone density. We can either try and improve our peak bone mass with strategies to help prevent osteoporosis, or we might be able to slow down that age-related loss and hopefully help to reduce the risk of fractures. In terms of, go on ahead. Sorry about that. So in terms of how we diagnose osteoporosis, it is based on bone density. And clinically, and still in research purposes, dual energy X-ray absorptiometry, or DEXA, is the instrument that we use to measure bone density. Generally, we use it at the hip and the lumbar spine because they're clinically relevant sites, but at the hip or the proximal femur, that really gives the best overall predictor of someone's fracture risk. But also, even without a DEXA scan, if someone comes in with a Colles fracture, a fracture of the wrist, for example, then you can make a clinical diagnosis of osteoporosis if they've had a minimal trauma fracture as well. And so the advantages of DEXA is that it uses very low radiation, about the same amount as you'd get on a plane to London. So it's much lower in dose than, say, a chest X-ray. It's pretty fast, it's relatively cheap, and it does indicate one's risk of fracture clinically. So it is a clinically relevant measure. And there are a number of rebates available, so for example, for people over 70 and so forth, or with conditions, medical conditions that predispose them. So, and on the website, you can get some information about who is covered on Medicare for DEXA. And World Health Organization defines osteoporosis based on bone density values, or T-scores. And basically what it does is it converts the person's bone density, comparing it to a young sex-matched adult. So, for example, a T-score of 0 would mean that the person's bone density is the same as an average young person of that same sex. And then anything, a negative T-score means that the person's bone density is below the person of the same sex of a young person. And so they define normal bone density as anything above 1 standard deviation. And then if you have between -1 and -2.5 standard deviations, that means you've got osteopenia or low bone density, and then below -2.5 you're considered to have osteoporosis. And then established osteoporosis is where you've got a bone density below -2.5 and or you've had a fracture before. And so there's different scanning machines, and they have different sort of printouts, and this is a printout from a hologic machine. And you can see there it gives the person, this is at the lumbar spine. So if you look at L1 to 4, you can see it gives the actual bone mineral density, which is not that relevant in sort of grams per centimetre squared. But then it gives you a T-score and a Z-score. So this person's T-score is -1.98, which means that they've got, on this definition, they've got osteopenia, they've got low bone density. So their bone density is about 79% of some young person. But you can see there that they've also got a Z-score of -1.01. And a Z-score is now comparing that person with someone of the same age. So it's saying, well, obviously as we get older, we're going to lose bone density, but is the bone density what you would expect for someone of that age? And you can see that this person, they're still lower than you'd expect for someone of their age. They're 88% of what you would expect someone of this age. And you can see there, it's plotted there over on that little graph on the right. The person's about 50-something. And you can see that that middle line, in the yellow line in the middle, is the average. And you can see that they're below the average, and they're plotted their value there. So it gives you an indication. And that red dotted line is the fracture threshold. You can see that that person is nearly at the fracture threshold where they're much more likely to have a fracture. Now, if you're going to get the DEXA, you're going to have a scan, you need to have it scanned again on the same machine and not less than sort of a year intervals. You need to have it 1 year or more because bone doesn't change that rapidly. So you need to give it time to be able to detect true change and not just measurement error from the machine. Now, what you may see is transmission ultrasound. And at the chemists, you can often see them asking, come in and have your bone density measured. And what they're using is not DEXA, but they're using transmission ultrasound. And you can see there's a little instrument. It measures at the calcaneus or the tibia or the patella, and it doesn't actually measure bone density. It measures speed of sound, which has an indication of the amount of bone density, but it's not a true measure, and so it's not recommended as an appropriate test for measuring bone density. So if you want to have someone diagnosed and see whether or not they've got osteoporosis, then this really isn't recommended, and they need to go off and have a DEXA scan. You may also see in the literature the use of peripheral quantitative computed tomography, which is called pQCT for short. And essentially this is like a CT scanner, but at the periphery, and involves less radiation dose. And what it does, as it suggests, the name suggests, it scans the periphery. It scans the distal radius or the proximal tibia or the distal femur, and it doesn't scan those clinically relevant sites such as the proximal femoral spine. But it does give you very good and very precise bone density determination, and also measures other things that you can't get from DEXA, such as the trabecular spacing and bone geometry and so forth, which, as we do know, does affect bone strength and fracture risk. But it's more used for research purposes and not really clinically. But you may come across it if you're reading in the area. So what are the risk factors for fracture? There's a number of modifiable and non-modifiable. And the non-modifiable factors that increase your risk of fracture are being female, Caucasian or Asian, having a small body build, delayed puberty or early menopause, having a previous osteoporotic fracture, and I'll talk about that a little bit later, being older, over the age of 60, taking oral corticosteroid use for a long time, and also certain medical conditions. So some of these medical conditions or drugs that people are taking, such as anorexia nervosa, rheumatological conditions such as rheumatoid arthritis, malignancy, cystic fibrosis, GI disorders such as Crohn's disease, liver disease, being on certain drugs, as I've mentioned, corticosteroids, heparin, your immunosuppressives, some antidepressants, anti-epileptics, aromatase inhibitors that are used for breast cancer treatment, and or being immobilised. So it may be that you're treating someone for some totally different condition, or you've got a patient, but they may actually have osteoporosis as pardon me. So they may actually have osteoporosis just as part of their condition. And so you'd need to be mindful of that. It may affect your treatment, but it may also mean that you might want to recommend the person on to have their osteoporosis investigated further. Then there's a number of modifiable factors, obviously some of which we're going to talk about. That's little or no exercise, cigarette smoking, high alcohol intake, low body weight, low calcium, and being a frequent faller. So the other determinants of osteoporotic fracture, as I mentioned, is falling. And several studies have really confirmed this. One from Dubbo, a large epidemiological study of osteoporosis, and they found that the factor that was most highly correlated with someone's risk of having a hip fracture in an older age group was whether they had fallen in the past year. So certainly asking about someone's history of falling is going to give you a bit of an indication. And this was also found in another study where they found in men that, again, falling in the previous year and being unable to complete a narrow walk test where you put one foot in front of the other and walk along a straight line, they were both correlated with having a hip fracture. So again, some simple clinical measures to help indicate someone's risk of fracture. But having a prior osteoporotic fracture certainly increases your risk of having another fracture. 1.5 to 9.5-fold increased risk of having another fracture depending on how old you are when you have it, how many prior fractures you've had, and where the particular fracture has been in. And in particular, the site that really increases your risk of having another fracture is having a vertebral fracture. If you've had a vertebral fracture, there's actually a 4-fold increase in your risk of having a second one, and 20% of people will fracture within 1 year, not just necessarily at the vertebrae, but at another site. And so certainly, again, this patient group is highly at risk of having another fracture and needs to have interventions to try and reduce that risk. And you might have heard the term mentioned, the fracture cascade. And this graph here really shows you the normal morbidity associated with age in that sort of pale orange across the age and the amount of morbidity on the y-axis. And then you can see the excess morbidity resulting from fracture. So we know that the peak time of getting a wrist fracture is sort of the post-menopausal years, so the late 50s. So someone has a wrist fracture, but you can see that they recover pretty well and their morbidity goes back to what you'd expect for their age. Then they have I might try this little groovy little things. Then they have a vertebral fracture here. Again, their first vertebral fracture, their morbidity comes back to the same as you would expect for their age. Then they get a little bit older. They have another vertebral fracture, but this time it really adds a lot of extra morbidity to them. You can see here they have another couple of vertebral fractures, and their morbidity is really going up. And then down the track, because they're at high risk of having another fracture, they end up having a hip fracture, and they've got a very high amount of morbidity, much more than you'd expect for someone of their age. And so I think this is where health professionals can really play a big role, because what their studies have found is that a lot of people have had a wrist fracture. Their fracture's been managed really well. Say, for example, it's been put in plaster by the orthopod, but no one's actually treated them for their osteoporosis. And so health professionals have a really big role to play to ensure that someone who has a risk of osteoporosis or presents with a fracture, that their fracture is not just being managed, but also that they're having investigations and then treatment for the fact that they've got osteoporosis. And so, as I said, this is where health professionals can play a big role to help ensure that that is happening, so that we reduce this fracture cascade. There are also a number of what's called fracture risk calculators, and again, you can find these on the Osteoporosis Australia website, and you can click on these and go to them. But what these calculators do is they give someone an individual risk profile for that person about their likelihood of suffering a fracture. And there's a few different ones. There's the FRAX, which is the World Health Organisation one, and then there's some ones that have been designed for Australians, the Garvan Fracture Prognostic Tool and the University of Western Australia Fracture Risk Calculator. And they're all sort of similar, but the FRAX has had a lot of work into it, but it doesn't have Australian data into it to give a sort of accurate picture for Australians, whereas the other two do. But for example, they're very similar. The FRAX, what it does is it evaluates for an individual patient their 10-year probability of having a fracture, and it uses knowledge of clinical risk factors plus the person's bone mineral density at the femoral neck. So you'd need to have the person's DEXA scan, and what you do, this next slide here shows you plug in details with it. And this one you can see here, it asks you questions: have they had a previous fracture, has a parent fractured a hip, are they a smoker, and so forth. You type in their femoral neck bone mineral density T-score, and then it calculates for this person what's their 10-year probability of fracture. So you can see that this person here has a 20% likelihood that they're going to have a major osteoporotic fracture and a 3.7% likelihood of having a hip fracture. So it can give people some good information. It might also be useful as a tool to help motivate them to perhaps do something about it, give up alcohol or smoking. It's very interesting to change the yes to a no for smoking to see what happens to their risk of fracture. So it can be a very useful tool. Now, if we move now on to the management of bone health and treatment of osteoporosis, and I'm really going to cover these different areas, the medications briefly, the nutrition, and then exercise and falls. So just medical management. Now, this just provides a sort of a summary of when you would put someone on drug treatment or the recommendations, and you can see here that basically anybody that has a bone density less than 2.5, so that is their osteoporosis, it's recommended that they undergo medical or drug treatment for their osteoporosis, whether or not there's a fracture present. And if someone has a T-score above -1, that is they've got normal bone density, then you just reassure them and follow them up and so forth. And so again, you can see that what this is recommending here, that even people who have osteopenia or low bone density but don't have a fracture, they should be treated. So it gives an indication of when medical treatment or drug treatment should be instigated. And I'm sure the studies have shown that there's a lot of people here that aren't being treated, and they should be. Now, there's a lot of very good randomised clinical trials that provide evidence to support the efficacy of these drug medications to reduce fractures in men and in women. You can see that, I'm not going to go through all the evidence, but the different drugs, you can see there's evidence in both men and women, depending on the drug. Obviously, some can't be used for men. And there is evidence for at different sites, so some for the vertebral, some for non-vertebral. But there's certainly very good randomised controlled trial evidence to support the use of these drugs to reduce the risk of fracture. And again, this is I've taken this from the medical fact sheet from the Osteoporosis Australia website, and I'm not going to go through all of this, but just to say that there's not a one-size-fits-all drug for treating patients with osteoporosis or with fracture. There's a number of different drugs. They work very differently. They are taken differently. Some are tablets, some are taken as injection, some are taken every day, some are taken an injection once a year. Some can only be used by women. Some are on the PBS, some aren't. They have different side effects and so forth. So all of these would need the benefits and the risks, as well as all the personal factors, would need to be weighed up to decide, for the doctor to decide which is going to be the best drug for that patient. And it depends whether they had a fracture of the vertebrae versus a fracture in the lower limb or so forth, because some of the drugs work for vertebral fractures and others for other fractures. So there's a whole range of the decisions that are taken into account. Probably the most common drugs, however, that are used to manage osteoporosis are your bisphosphonates, things such as Fosamax and Actinol. And as I said, they're the ones that are most commonly used. They're anti-resorbtives, where they reduce the amount of bone resorption that's going on, and obviously have benefits, as I said, for reducing risk of fractures. And just going to mention vertebroplasty, you may have seen this, but for people that have had a painful osteoporotic fracture, what they have been doing is that they can inject cement into that sort of the wedge fracture to try and blow it up and support it. And there's been two good randomised controlled, placebo-controlled trials that can that have looked at whether or not vertebroplasty is useful in reducing pain in these painful osteoporotic fractures. And the study by Rochelle Bookbinder from Melbourne in the New England Journal of Medicine, which is obviously a highly prestigious journal, found that there was no difference in patients who had the procedure versus those that had a sham procedure, where they actually went through the whole operation but just didn't inject any cement into it. But there were some criticisms particularly by the people that were performing the surgery, that it may work for subgroups, for people that have had pain for shorter or longer durations, or for people with more or less severe pain. But the study by Margaret Staples in British Medical Journal last year pulled the data from the Bookbinder study and from another randomised controlled trial to be able to look at subgroups, and still found that there was no difference compared with placebo. Now, given the potential side effects and the very dangerous side effects that you can get from this procedure, the benefits, there's certainly no benefits that could be evident in these trials, and so vertebroplasty really isn't recommended. So now moving on to nutrition. And just again, the fact sheets for calcium and vitamin D are available, and again, well summarised this area. I'll just sort of quickly move through it, but just to show that our calcium intake increases as we get older, because of the fact that the less calcium is absorbed through the gut, and we lose more in the kidneys and so forth. But certainly we need more, and really 3 to 5 serves of calcium a day are needed for older people. And we don't really just need to be advising people about where the calcium best comes from, and it obviously comes from our sort of dairy products and things. But getting people to have a healthy diet with a lot of fish and sardines and nuts and selected green vegetables and so forth. But what about calcium supplementation? And there's certainly, from the randomised controlled trials, that have looked at whether or not it's effective in older people. Depends on the measured endpoint. Some have looked at bone density as their endpoint, where the others have looked at fracture, which is obviously the endpoint that we really want to affect. And there can be some differences depending on the trial and so forth. But certainly the calcium supplements are mostly combined. They're generally, all of them are combined with vitamin D, so it's hard to tease out the effects of the either or. But there's been recently some safety concerns raised about whether or not taking excessive calcium can increase the risk of heart attacks. So that sort of had been raised in some studies in the British Medical Journal recently. And so Osteoporosis Australia, their current recommendations for calcium supplementation are that these are the people that should be taking calcium supplementation, those who are getting insufficient dietary calcium intake, they just can't manage to get enough in their diet. If they've got osteoporosis, they should be taking as well as a treatment. If they're taking osteoporosis medications, all of those really need to be taken with calcium. If people have been on corticosteroids for more than 3 months, they should be taking calcium. And also anyone taking any medications or having any diseases that can impact on bones. And the safe recommended dosage that they recommend is 500 milligrams to 600 milligrams a day. What about vitamin D? Vitamin D certainly is very essential for allowing calcium to be absorbed, but also for mineralisation of bone, muscle strength and balance. And we get most of our sources from the skin, but some a little bit from our diet. But there's a very high prevalence of vitamin D deficiency in all ages in Australia. Even, you know, surprisingly, we think we live in a relatively sort of sunny country, but there's a lot of prevalence of vitamin D deficiency. And the thing as well is that there's a limited number of foods that are actually rich in vitamin D, so it's often hard for people to get the dietary intake that they need, because it comes from things like your oily fish like sardines and mackerels and so forth, and so people may not be getting enough vitamin D. Also, there's recommendations of vitamin D and health in adults in Australia and New Zealand. They've come out with a position statement for how much sun exposure we need, and it's a bit hard because we hear the sun smart, you know, we need to stay out of the sun for our risk of melanoma, but we also need to have some sunlight is good for our health for a number of reasons for the vitamin D. So these are some recommendations of sun exposure, and it depends on whether you've got moderately fair skin. If you've got darker skin, you actually need to be out in the sun for longer to get the same amount of vitamin D. And again, it depends on your latitude, you know, summer versus winter and where you are in Australia. So this again contains some information about how long you need to stay out in the sun to get what we need and the time. And there are a number of groups who really are probably at risk of vitamin D deficiency, and you need to suggest that they might need to have their vitamin D levels assessed. You know, they can do that in the blood, a measurement in the blood, but also suggest that they try and increase their vitamin D intake as well as their exposure to the sun. So people who are elderly, people who are housebound or in residential care, naturally dark-skinned people, people who cover their skin for sort of cultural or religious reasons, and sort of babies of vitamin D deficient mothers, but certainly those groups are very high risk of vitamin D deficiency. What about vitamin D supplementation? Well, meta-analyses have been conflicting with some finding significant effect and others no effect. And meta-analyses, it depends on which trials you let in for inclusion, and so it may be that they've let in different trials. But this was a very recent study where they basically pulled a number of different studies, and I'll take you through this, but they pulled a number of different clinical trials, and they wanted to see whether the outcome depended on how much vitamin D you actually had, because there may be a dose relationship. And these are forest plots here. At the bottom here, basically you can see that if it's to the left of the line, it means that vitamin D protects against hip fracture, and it's to the right of this middle line, it means that it actually exacerbates the risk of hip fracture. On the left, we have hip fracture, and on the right, we have non-vertebral fracture. And oops, I'll get rid of that. So you can see here that this is the studies, summarising the studies where the people had a low dose of vitamin D. And you can see that because the little blue diamond crosses the line, there was actually no effect of vitamin D on preventing fracture, either at the hip or at the non-vertebral sites. So if you took a low dose, then it wasn't really effective, and that was doses sort of up to 360 international units a day. But if you look at the results where they summarised the studies where they took a lot of more vitamin D, so over sort of 700 or so international units a day, you can see that those little blue diamonds don't touch the line now, which means that there was a significant protection against fracture with the vitamin D dosage, showing that it did seem to be dependent on how much you took. So from this study, they recommended, or they suggested, that the results showed that high-dose vitamin D supplementation that is more than 800 international units daily, was somewhat favourable in preventing hip and non-vertebral fractures in people who are 65 years and older. And this really does agree, I think, with the recommendations that are now out there from the position statement in terms of how much they recommend for people. And they say that if people don't get, they get some sun exposure but they don't reach target levels, then give them a daily dose of sort of 600 or 800 international units a day, depending on their age. And then that could go up more depending on, if they're an older person and you want to reduce fracture risk, you may need to take 1,000 international units and so forth. So there are certainly some figures for general recommendations about how much people should be having. So move on to exercise now, and we all know that exercise is beneficial for bone health. That's sort of well established. But our role of our aims of giving exercise at different stages of the lifespan in terms of trying to promote bone health differs. So if we're prescribing exercise for younger people, what we really do want to do is give them exercise that's going to increase their bone density, improve the bone structure to maximise their peak bone mass. In sort of your early adults, again, the aim of the exercise is again to try and increase or maintain bone density. Sort of around the menopause, again, the exercise does want to try to be bone loading to try and maintain bone strength by slowing the rate of loss at menopause, and the same again in men. Again, as people get a little bit older, our focus is a little bit more around sort of muscle strength and balance now. But in people who have had a fracture before or have got very, very low bone density, then really our aim is not to try and improve bone density. It's not to try and load bone. It really shifts now to being exercise that would be recommended by a physio, where you're getting individual exercise prescription and really working on things like mobility and function, muscle strength, balance and posture. So it then becomes not bone loading exercise, because if we actually tried to load bone, we'd actually may damage the bone and give them a fracture. So the aim of the exercise shifts, and therefore the types of exercise that we're going to recommend is going to be different across the age span. So what is the best types of exercise if we really are trying to stimulate bone and load bone? And a number of very good animal studies have shown that higher strain magnitudes, that is higher loads, higher strain rates, so faster exercise, fewer loading cycles, altered strain distribution different to what is normal, what we usually have, and rest periods between the bouts are effective. And so if we translate that into exercise prescription, what that means is that the high impact exercise, it's high strength training where we use high weight and high load and low repetition, very dynamic exercise, it's very fast, few repetitions and a variety, so that bone doesn't get bored and get used to the same type of exercise. So that's the type of exercise we would prescribe if we're trying to load bone. So if we look at across the lifespan, in the childhood years, the studies that have looked at the randomised controlled trials, and this is a meta-analysis, showed that the best time to maximise the effects of exercise on bone is really in those sort of early pubertal or pre-pubertal years, and that the effects of the same type of exercise once they've been through puberty is much less. So the story then is to make sure that during those sort of growing years, particularly during pre-puberty and early puberty, that we can really try and maximise the effects of exercise on children's bones. A lot of very high impact exercise. And therefore it needs to be also school-based programs, really implementing them in schools and not just sort of at home. And the question really remains that if you exercise as a child and you increase your peak bone mass, is that going to be good for when you're older and that's when your risk of fracture is? And there's been a number of different studies, obviously indirectly looking at whether that is the case, and it does seem to be that you can maintain a lot of the gains that you get when you exercise in childhood as you get older and you detrain, so that there is benefits to be active when you're younger. We'd also need to remember that if girls are exercising excessively or they're very lean and they lose a lot of weight and their period's stopped, that has a detrimental effect on bone. So amenorrhea or loss of periods can have a detrimental effect on bone, and you don't necessarily get the bone back when your periods resume because you stop training or you put on some weight. And it really is associated with what we call this female athlete triad, where people that have their period stopped, they're more likely to have low bone density in association with that, as well as disordered eating. So if you see someone, you're working with athletes or younger people and they do have their period stopped, you'd need to be thinking in your mind, well, maybe they've also got low bone density and disordered eating, and they're also more likely to get bone injuries such as stress fractures. If we look at the premenopausal and the menopausal, the premenopausal years, then really this is a time when you can be doing lots of high impact activity, and a lot of the studies have looked at brief bouts of high impact activity such as some jumping that you can do anywhere with no equipment, and you can do it regularly in small bouts during the day. Now this is the results of a meta-analysis of the different studies that have looked at various types of high impact regimes, the femoral neck results at the top and the vertebral results at the bottom. And you can see here, I'll use my little tool here, that there is certainly a significant benefit from if you average and pool the results of the studies at the femoral neck. So certainly benefits in terms of improving bone density at the femoral neck, but no significant effect of these activities at the spine. Oops, and that's what I did my own before. And so basically some other meta-analyses support the previous one, where they found that high-impact exercise alone was effective at the femoral neck but not the lumbar spine. So what you need to do to be effective at both sites is to also, what they found, is to add in high-magnitude strength training. So a combination of sort of high-impact exercise plus high-magnitude strength training, where you're lifting heavy weights and doing fewer of them. And you need to load the sites that you're interested in. So you need to do exercise that's going to load around the hip and load around the spine. What about the postmenopausal years? Well, again, the mixed loading programs are shown to be effective with sort of jogging. When we talk about mixed, we talk about sort of jogging with other lower impact activities such as stair climbing, but also sort of some impact as well and some high magnitude strength training. But they found that if you only did high impact alone or odd impact alone, it wasn't effective. So you needed to add in the sort of strength training as well with it. And a Cochrane review, again, summarising 43 randomised controlled trials in the area, again found that the spine, you needed to do combination programs to get the benefits for bone density. At the femoral neck, that they found also that strength training on its own, progressive strength training, was effective. But I think the message coming in is that you'd want to do a combination program to get the best results. What about walking? Well, the results of meta-analyses in postmenopausal women have been conflicting, but the most recent, which was in 2008, found really no effect at the lumbar spine and probably only a very small positive effect at the femoral neck that probably wasn't clinically significant. So whilst walking is very good for fitness and for other health benefits, if you're wanting to really improve bone density and for the bones, walking is not really the exercise for that. And that's because it doesn't load the bone enough and it's very repetitive. What about maintenance of bone effects with exercise in adults? Well, what the studies show is that unlike in childhood, the positive bone effects appear to be lost when you cease the exercise. So what you need to do then is, it's really important to build in adherence strategies. The person needs to be exercising for the rest of their life, so you need to try and tailor the program to the person, come up with adherence strategies for them and how it's going to best work in with their lifestyle, with their preferences, and work on sort of variation so they don't get bored over time. So that's really important. What about the effects of exercise in men? And I'm going to skip the next couple because we'll get through this, but essentially say there's much less research in men, but still the results also confirm that exercise is beneficial in men, and that, as I said, it's not just a problem in women, so men also need to be undertaking exercise. And I'll just sort of skip through these next two studies which just show that point. Also, there's been quite a few studies now looking at exercise effects in special groups, so breathable spinal cord in terms of trying to improve their bone density or prevent or slow down bone loss that they may be getting either associated with their condition or because of the medication that they're on. What about the group with osteopenia or osteoporosis or fractures? That's sort of the different groups there, and we'll just briefly talk about those. And this is a study in early postmenopausal women, so they're relatively youngish, in their sort of early 50s or so. They had low bone densities, but they had them doing a number of high-impact activities, jumping, skipping, weights that were up to sort of 90% of their 1RM. And after 4 years, you can see that there was certainly a loss of bone density in the pink, the control group, but slight gain in bone density in the exercise group at the lumbar spine and just a slight loss at the total hip. So certainly benefits of exercise with people with low bone density when they've gone through menopause. Another study looked at a 30-month program in older women with low bone density, and again they had them doing some jumping activity, strengthening, balance. They did some daily home exercise, supervised training once a week. They didn't find any benefits of exercise at the lumbar spine or hip in terms of bone density, but interestingly what they did find was that there were 6 fractures in the exercise group and 16 fractures in the control group, because we know that exercise has benefits over and above just bone density. So it may be that it's improving other aspects of bone structure and things that we're not measuring. Again, at the 7-year follow-up, the same sort of thing. No hip fractures, but 5 hip fractures in the control group. So again, benefits for fracture prevention. And again, this was a 12-year study of fracture rates. Again, they did find benefits in bone mineral density over that time in the exercise group compared with the control group. And again, fracture risk was reduced, not significantly, almost there, 0.07, but 10% of fractures in the exercise group and 27% in the control group. What about the effects of exercise in people with vertebral fracture? We know that this group are highly at risk of having another fracture, and should we be exercising those people? And sometimes the doctors are even saying to them, no, you shouldn't be exercising, your bones are too weak, which isn't the case. What they shouldn't be doing is bone loading exercise. You certainly shouldn't be working on trying to load the bone, but exercise that focuses on balance training and posture and strengthening and so forth certainly has been shown to be effective and safe in this group. And this table just shows the results of several studies and showing benefits in terms of pain and function and reduced use of analgesia and so forth, and just a couple of other studies as well, including our own study where we did a physiotherapy program that included exercise really aimed at including extended posture and so forth, and not, as I said, not at all doing any, there was no impact exercise at all, and the focus was very much around function and posture and balance. And this is a very nice summary flowchart that you can find at the osteoporosis.org.au in their information about exercise, and they give you a bit of a flowchart about what you should do depending on whether the patient has osteoporosis or they've had falls and so forth. But again, it's really following as to whether you're trying to load the bone or whether the aim is different. And in older people, it really becomes around, as I said, falls and mobility. And this is a very good resource that you can use. It's a little booklet, pamphlet that tells you about much more detail about exercise and fracture prevention, again, at that site there that you can go to. So now just to finish off with falls prevention, and we know that falls is really important as a risk factor, and you can do some simple risk screening. As I said, asking them about the history of falls in 12 months, assess their balance and their mobility. You can use the timed up and go test, where you just time the time it takes a person to get up out of a chair, walk around a marker 3 metres away, come back and sit back down. If they takes them longer than 12 seconds, that indicates they've got an increased risk of falling. There's also a tool for general practice called the Quick Screen, which is a risk assessment tool that can be done quickly, and it assesses a number of different aspects around falling, such as medication use and balance and proprioception and so forth. So there are a number of different risk factors for falling shown here: muscle weakness and footwear and medications and so forth. And then depending on what you find, there are a number of different interventions that you could give the person depending on whether they're taking, they've got polypharmacy or they've got problems with their vision. Obviously, if that's contributing to their risk of falling, then you need to have them assessed for their vision, an occupational assessment for their environment and so forth, and then exercise. So I'm just going to go through finally the results of this Cochrane review. A very recent Cochrane review came out this year, and it really evaluated all of the interventions for preventing falls in community-dwelling individuals. And they found 159 randomised controlled trials in the area. You can see that the majority of them were looking at exercise, as well as sort of multifactorial programs, which included a combination of different interventions. And what they found was, in terms of exercise, they found that multiple component exercise programs reduced the risk of falling. That is, programs that included both strengthening aspects as well as balance aspects. And they could be either group-based or they could be home-based. Both of those were effective, but they needed to be multi-component, not just balance, not just strengthening, but the combination. And certainly there's been a lot of work around the Otago exercise program that people can do in their own home around reducing the rates of falling. A bit slow. Tai Chi. They also found that Tai Chi could reduce the risk of falling, but bordered on significance for rates of falling. But certainly Tai Chi is another exercise that you could recommend to your patients, and again, it's something different. Then in terms of multifactorial assessment interventions, then there's a number of different ones where these include an individual risk assessment. That is where you go through, you assess the patient on all the different things that you know could influence their risk, and then you intervene on each of those. So rather than, it's not a one-size-fits-all, you really go through and you tailor the intervention to the person. And what they've found is that these certainly can reduce the rates of falling. Vitamin D supplementation. They found that overall vitamin D supplementation didn't reduce the rates of falling or the risk of falls, but they suggested that it might do so in people who have lower vitamin D levels before treatment. And that probably makes sense. I mean, if your vitamin D levels aren't low, perhaps just giving you more doesn't make a difference. But if you have got low vitamin D levels, then giving you some vitamin D supplementation may be effective. And then home safety and modification intervention. So, looking at whether they've got risks at home, the bath rails and so forth. And again, they found that these were effective, but they found that they were more effective in people who were higher at risk of falling, such as people who had very severe visual problems. And also they were more effective when delivered by an occupational therapist. So I think that's very good support for the expertise of the occupational therapist in being able to really look at those and assess the safety modifications that were needed and being able to give the best modification. And then what about just interventions to increase knowledge and to educate people? And what they found was that wasn't effective. So it's not enough to just tell people, look, you're at risk of falling and you could do this or that. Just knowing about it and educating people doesn't reduce their risk of falling. They have to have some other intervention to address the actual risk factors. And lastly, you may have seen or heard or used hip protectors, and they've often been used perhaps in older people in care, because if people are thinking, well, if you can't stop the person from falling, let's try and minimise the impact of the fall. And this was a very recent systematic review from last year, where again they found 16 studies that had involved over 16,000 people. And what they found was that there was really no benefit for the majority of older people living in their own home. But they found that they may reduce hip fractures in nursing home residents, but their effect appears to be much less than that of the earlier studies. The earlier studies were really quite supportive of wanting to the effect of these, but the better controlled studies that have been done more recently haven't supported such a benefit. And also, there certainly are a lot of issues around acceptance and adherence, and the difficulty putting them on and so forth. So in summary, osteoporosis is diagnosed by DEXA. Bisphosphonates are the main drugs that are used for fracture reduction, but more people should be on the drugs than they are. They're not being managed. Vertebroplasty for vertebral fracture is no better than sham, so really shouldn't be recommended. There should be an emphasis on adequate diet across the lifespan and, if necessary, calcium and vitamin D supplementation. High impact exercise and strengthening during childhood, early adulthood, and strengthening and balance exercise really in the older years with an emphasis on falls prevention. So since we've just got a few minutes, I'll just quickly take some questions. So I'll have a look here at the questions. And Wendy has said, what significance does genetic predisposition have generally? And that's a good one. Of the major predictors of your bone density is going to be your, your family history, if you like. So certainly genetic factors play a key role in predisposing you to low bone density as well as to risk of fracture. So that's another thing and why it's important to ask about someone's family history. Wendy's also asked, do you mean using the same DEXA machine each time? Yes, that is what I mean, because the machines are all different in terms of their readouts, and so you really need to be scanned on the same machine each time, if certainly if that's possible, rather than having it on one machine, because it's very hard to compare across machines. Now, Joy has said, I've heard that bisphosphonates increase the brittleness of bones, i.e. the actual bone strength is reduced even though bone density might seem to be improved. And there had been sort of a little bit of about that. There's been some rare events associated with sort of osteonecrosis of the jaw. And this was a cancer patient was taking sort of some bisphosphonates of higher than usual dosage that you might give, and they found sort of that there have been some cases reported with the bisphosphonates in others as well, but they're very rare, rarely reported. So I think that that sort of has been documented as a risk, but certainly the majority of the studies have really found very substantial benefits in terms of fracture prevention. So that's, I think, not really a risk. The only thing they ask is that if you've got sort of poor dental hygiene and you're going to see you need to have an extraction, you need to sort of advise the dentist if you're on taking bisphosphonates. Sorry, someone has said, Genevieve has said, if someone is taking high-dose vitamin D, is it better to take it once a day or spread over a longer period of time? That's a very good question, Genevieve. Is that a trick question for me? Do you know the answer? I'm not exactly sure on that one. We can certainly get back to that one and get back on that one, but I don't know the answer to that one. Does anyone else have the answer to that one? No. Okay, but we can certainly post that out and let people know about that one.
Hello, Kim, it's Jen.
Yes.
Actually, I was just retyping that the original question was, if someone is on high-dose vitamin D, is it better to take it once a day or 2 or 3 times?
Yeah, I'm not really sure about that, Genevieve.
Okay.
Do you know?
That's okay.
Yeah. Mm-hmm. Okay, so GPs I know prescribe, Joy has said, GPs I know prescribe high dose once per week. Okay, so. Okay, we're basically nearly finished, and Nikki Osborne, can a copy of the presentation slides be emailed to attendees? I'll certainly speak to Genevieve. I don't see why we couldn't do that, so we'll try and email those out to you. And Alison has said, I was advised to take vitamin D at night by a specialist. So certainly, I think there's some good questions around vitamin D, and I'm probably not the best to answer about the individual specifics about vitamin D. So Genevieve has also said, is it possible to go from osteoporosis to osteopenia? Certainly, you can do that depending on where you are, and obviously osteoporosis means anything under -2.5. So if you're just under -2.5, you may be able to become osteopenic, but it depends. If you're way down at -4, you're probably not going to be getting back up to above minus 2.5. So it does depend on how osteoporotic you are, but certainly interventions can add some bone to the skeleton. It is possible to have some improvement, but it's probably not possible to have really large improvements as we get older, and as we that's adding a lot of bone to the skeleton is really what you do during childhood. And so as you get a bit older, as I said, some interventions can help, but you're probably not going to go to normal. So I think that's really important, a good question, important to point out to patients as well that even though you might be really diligent with your exercise and so forth, if you have a remeasurement, you may not be, you may not see a lot of change, but that's fine because you don't know what you would have been in terms of the amount of loss that you might have had.
Okay, Kim, it's Jen here. Look, given it's just right on 1:30, can I say thank you very much on behalf of everyone, and to just remind people to fill in the exit survey, and thank everyone for joining the webinar today. Thanks, Kim.
Thank you.